Welcome, everyone, to our research series webinar. I am so incredibly thrilled to have Song-Yang and Tony Lam joining us today to speak about their incredible research on kidney and the key to fighting obesity. Thank you so much for joining us today.
Thank you.
Thank you so much, Dr. Lam. I'm wondering if you could introduce yourself, Dr. Lam, and tell us a little bit about your research.
My name is Tony Lam. I'm a senior scientist at the Toronto General Hospital Research Institute, which is part of UHN. My lab focuses on finding novel therapy of therapeutic targets for people with obesity and diabetes and the associated complications. Our lab experimental models involve using rodents, as well as more recently working together with clinicians from the UHN doing studies in humans, particularly with nephrologists, hence the topic of our for today. And I'm also a professor of physiology of medicine at the University of Toronto, as well as the associate director for the Benning and Best Diabetes Center. And my postdoc, Song-Yang, will be presenting the scientific portion of the studies.
Wonderful. And
Nice
I'm
to meet
wondering,
everyone.
thank you. I'm wondering if you can also introduce yourself, Song-Yang.
Yeah, my name is Song-Yang, and I have been working in Dr. Lam's lab for almost 5 years, and my research interest is on like the way to how the body regulates like feeding as well as like glucose homeostasis. Yes.
Amazing. Thank you. So I am going to turn it over to you, Dr. Lam, to present this incredible research. Thank you so much, both of you.
So I'm going to present a few introductory slides for today, and I'm going to ask Song-Yang to control and move forward the slides for me. And then after the introductory slides, Song-Yang will go into the details of a recent study that we published with nephrologists from UHN, as well as from University of Michigan, looking at novel therapeutic targets for obesity. Next slide, please. People with obesity-associated type 2 diabetes have quite a few medications for options, medications that are responsible for lowering blood glucose levels. The options, as you can see in the slides, first-line therapy is Metformin, and then there are the GLP-1 agonists and DPP-4 inhibitors, as well as the SGLT2 inhibitors. And then, of course, the last resort for people with type 2 diabetes is insulin injection. We are very interested in understanding how particularly Metformin works. Knowing that it's a very effective agent, knowing how it works will give rise to novel effective therapies, in particular lowering glucose levels. Next slide. This is a diagram that we put together to illustrate part of how Metformin works. If you will just follow me from the left of the slides, you have Metformin or intake of Metformin to the body. And then these are the distribution of where Metformin will go throughout the body after it's taken in. Of course, once it goes past the stomach, you're going to hit the intestine for absorption. And then, of course, a bunch will not get absorbed, will go to the stool. And once it gets absorbed into the blood, as you will follow the arrow of the diagram to the sort of the middle part right now, and then you go from the blood, it would then also enter the liver. But then eventually, Metformin will get clear by the kidney via urine, will exit the body. So Metformin distribution is mostly in the intestine, in the liver, and in the kidney. Interestingly, some of our works, as well as others that has been shown in both studies that has been done in humans as well as in rodents, that part of the way that Metformin works in lowering glucose level, hence the term anti-diabetic effects, are via his signals that you can generate from the intestine. Before metformin has a chance to enter the blood, metformin in the intestine could already exert these anti-diabetic glucose-lowering effect. And a lot of the pathways within this intestine section remains to be elucidated, but it does give rise to future opportunities for novel anti-diabetic therapies that could mimic or even be as effective or even more effective with less side effect than metformin. But metformin is known to enter the blood as well, to enter the liver, to exert its anti-diabetic effect that has been demonstrated by multiple laboratories, as illustrated by these references in the slides. And then eventually, metformin will exit via the kidney. As to which organs plays a more dominant role in mediating metformin actions remains unclear. But as one can envision, many of these studies require testing the concept in both humans and rodents, as well as their respective tissues that are needed to understand the underlying mechanisms. Next slide. Interestingly, with respect to the anti-diabetic effect of metformin defined as its glucose-lowering effect, studies have shown, particularly in respective or specific individuals, that metformin could also cause weight loss. And this should be followed with studies, because obesity is clearly, as we all know, is a global epidemic health issue. Approximately, with respect to overweight, it's about 2 billion people now who are overweight, about 650 million are obese. That was back like almost 7 years ago. I'm sure we would all agree that the numbers have skyrocketed recently with our change in lifestyle, COVID, being at home, as well as the electronics accessories that we have. People are just less inclined to exercise. With the rise of these incidents, it is an issue because it will lead to type 2 diabetes, as I've mentioned in the previous slide, as well as other complications, including cardiovascular disease, as well as cancers. So it is very important, in addition to understanding the anti-diabetic effect of metformin, we have decided to invest into understanding our time as well as resources, how metformin could lower weight, with the goal in coming up with novel anti-obesity targets. From here on, I'm going to pass the time to my fellow Song-Yang, who have carried out one of these studies. And he would also, to our surprise, we found, and he will illustrate how we found with this journey, that it turns out that kidney could be an important role, could be an important site of where metformin acts with respect to losing weight. So I'm going to pass the time to Song-Yang.
Thanks, Tony. And as Tony just mentioned, metformin is an anti-diabetic medication. But in spite of its glucose-lowering effect, clinical studies observed decreased feeding and weight, paralleled with increased blood GDF-15 levels in humans receiving metformin treatment. GDF-15 is a protein that is widely synthesized in different organs and is released into the blood. And the blood GDF-15 levels are modestly increased during obesity, diabetes, and kidney diseases. Importantly, when GDF-15 was injected into the healthy rodents to dramatically increase blood GDF-15 levels, the rodents displayed decreased feeding and weight. Interestingly, the increase of blood GDF-15 levels, as well as decreased feeding and weight, were also observed in the healthy rodents receiving metformin treatment, just like what people found in humans. And when GDF-15 was completely taken away in the rodents, the metformin effect on feeding and weight were gone, indicating that metformin lowers feeding and weight while increasing blood GDF-15 levels. However, in this process, we don't know where the increased blood GDF-15 levels after metformin treatment coming from. As Tony just mentioned, metformin is accumulated in the intestine, liver, and the kidney. And according to the historical literatures, the increased GDF-15 synthesis was observed in the intestine and the kidney in the rodents, as well as in the liver cells that were cultured outside the body after metformin treatment, suggesting that the above organs could be the source of GDF-15 in the blood. Therefore, we are interested in whether these organs could be the anti-obese target of metformin. By performing the upper small intestinal metformin infusion, we found that metformin in the upper small intestine not only leaks into the distal small intestine, but is also absorbed into the blood and increase the GDF-15 synthesis in the upper and the distal small intestine, as well as in the liver. By inhibiting the upper small intestinal GDF-15 synthesis, or exclusively infusing metformin into the distal small intestine, we further proved that the metformin effect on increasing blood GDF-15 levels and lowering feeding were independent of small intestinal GDF-15 synthesis, which suggests that the post-absorptive metformin is responsible for its effect on blood GDF-15 levels and feeding. Therefore, we directly infused metformin into the blood to mimic and assess the post-absorptive metformin effects. To achieve this, we used the male Sprague-Dawley rats and performed intravenous cannulation by inserting a cannula into the vessel of the rats for blood metformin infusion. And after 2 days of recovery, the high-fat enriched food containing 10% lard oil was given to the rats for 3 days. And consistent with previous studies, the rat received 3 days high-fat food or overeating, indicating that the feeding regulation in these rats were already disturbed. But the weight of the rat had not gained yet. By employing this high-fat feeding model, we can evaluate feeding independent of weight changes, because weight changes per se can regulate energy balance of the rats. And after 3 days of high-fat feeding and the day before experiments, the rats were fasted for 10 to 12 hours. And on the experimental day, a single shot of 200 milligrams per kilogram body weight of metformin, or its solvent, 0.9% saline, was infused into the rats via the intravenous cannulation. And the high-fat food was given back to the rats right after the infusion. Fasting triggered cumulative food consumption was monitored for 24 hours. We chose this amount of metformin because it has been shown to lowering feeding and blood glucose levels in the rodents. As compared to the rats received intravenous saline infusion, metformin lowered feeding from half hour until 12 hours after the infusion, and increased the blood GDF-15 levels at 1 hour and 6 hours, paralleled with decreased feeding. The liver and the kidney GDF-15 synthesis were also measured at the same time points. Kidney GDF-15 synthesis is higher than the liver under the basal condition. Interestingly, metformin increased the liver GDF-15 synthesis at 1 hour after intravenous infusion, which came back to normal at 6 hours. Well, the kidney GDF-15 synthesis was constantly increased from 1 hour until 6 hours after intravenous metformin infusion. When we inhibited kidney GDF-15 synthesis by infusing the wires interfering the GDF15 synthesis exclusively into the kidney. To our surprise, the intravenous metformin infusion effect on lowering feeding was markedly weakened as compared to the rats without receiving kidney GDF15 synthesis inhibition. Regard to the blood GDF15 levels, the GDF15 level increased at 1 and 6 hours after intravenous metformin infusion was also impaired by kidney GDF15 synthesis inhibition, which is in line with the impaired feeding phenotype. Although our current intravenous metformin infusion experiments showed that metformin increases blood GDF15 levels and lowering feeding via kidney, metformin is a long-term oral medication instead of a vessel infusion medication. And whether long-term oral metformin treatment also increases kidney GDF15 synthesis is not known yet. Therefore, we put a catheter into the stomach of the rat with or without kidney GDF15 synthesis inhibition, and gave the rats high-fat food for 15 days. Starting from day 4 until day 15, the rats were given daily stomach metformin or saline infusion to mimic the long-term oral metformin intake for total 11 days. By the end of the experiments, we firstly measured metformin concentration in the blood, kidney, and the liver, which are almost undetectable in the rats without receiving metformin treatment. This is to show that there's no external metformin contamination when we are measuring its concentration. And the daily stomach metformin infusion for 11 days elevated metformin concentration in the blood to the levels that is comparable with its blood concentrations in humans receiving long-term oral metformin treatment, which means our metformin treatment protocol has its clinical relevance. And at this clinically relevant metformin concentration in the blood, the distribution of metformin in the kidney and the liver were observed. And the kidney GDF15 inhibition did not affect the metformin distribution in the blood, kidney, and the liver. With the metformin distribution in the kidney and the liver, we further measured the GDF15 synthesis by the end of the experiments. Kidney, but not liver, GDF15 synthesis was increased after daily stomach metformin infusion for 11 days, paralleled with increased blood GDF15 levels. Well, the inhibition of kidney GDF15 synthesis impaired blood GDF15 level increase and did not trigger a compensation of increased liver GDF15 synthesis. Regard to the daily food consumption and the weight gain, daily stomach metformin infusion lowered feeding and the weight gain from day 1 until day 11 as compared to the saline-infused rats, which was weakened in the rats with the same metformin treatment but receiving kidney GDF15 synthesis inhibition. Thus, the long-term oral metformin treatment increases GDF15 levels in the blood and lowers feeding and weight via kidney. However, as you have noticed, all these concepts were established only in the rodents. Since we finally want to seek for novel anti-obese target in humans, we don't know whether the same situation also applies to human or not. Therefore, we set out looking for human kidney tissues resources for GDF15 level measurement. NAPTIN is a observational clinical study enrolling participants with kidney diseases across the US and Canada. Those participants, for most of the cases, came to the hospital due to the existence of protein in the urine, which is a symbol of kidney injury. Then the nephrologist took a tiny little bit of their kidney tissues for disease diagnosis. Once their kidney disease were diagnosed, they would be given the proper treatment as well as the opportunity to be involved in the NAPTIN study. And if they kindly agreed to participate in the study, their basic information, physical, kidney function, blood, and urine examination results were collected. And the kidney tissues remaining from the disease diagnosis will be carefully studied by the researchers. Ideally, we expected to use the remaining kidney tissues from the NAPTIN to measure kidney GDF-15 synthesis in humans and compare its levels between participants with or without metformin treatment, hoping to find out whether long-term oral metformin intake also increases kidney GDF-15 synthesis in humans. And also, we want to assess the correlation between the changes of kidney and the blood GDF-15 levels to figure out whether kidney GDF-15 synthesis contribute to the blood GDF-15 levels in humans. However, in reality, we found that almost all the participants in the NAPTIN did not receive any metformin treatment. And it is also very hard for us to obtain the blood samples to measure GDF-15 levels. Therefore, we decided to explore something alternative to analysis. We firstly tried to measure GDF-15 synthesis in the kidney tissues of humans. Kidney is a very complex organ and consists of 2 million of basic units called nephron. And each nephron has two compartments, the tubular interstitial compartment and the glomerular compartment. Since the tubular interstitial and the glomerular compartment play different roles in the onset of kidney diseases, the researchers from the NAPTIN carefully parted the two compartments and analyzed them separately. We found that both compartments synthesize GDF-15, but its levels in the tubular interstitial compartment is higher than the glomerular. And in the follow-up analysis, we only focus on the tubular interstitial GDF-15 synthesis, and will simply call it kidney GDF-15 synthesis, not only because the tubular interstitial GDF-15 levels is higher than the glomerular compartment, but also previous studies has shown that metformin treatment only increased the tubular interstitial GDF-15 synthesis in the kidney. After confirming the existence of GDF-15 in the human kidney tissues, we further found that the kidney GDF-15 levels were negatively associated with eGFR, which is a parameter to measure how well your kidneys are filtering your blood, and is positively associated with blood glucose levels. And what does these correlations mean? By searching for the historical literatures, we found that blood glucose levels were also negatively associated with eGFR and positively associated with blood glucose levels. Therefore, the similar changes of blood and the kidney GDF-15 levels in the context of different eGFR and blood glucose levels suggest the positive association between kidney and blood GDF-15 levels. which further supports what we found in the rodents, that the increased kidney GDF15 synthesis contribute to the blood GDF15 levels elevation. In summary, we found that metformin induces kidney GDF15 synthesis to increase blood GDF15 levels and lower food intake and weight. For the future studies, we will continue seeking for collaboration opportunities with nephrologists to obtain kidney tissues from humans receiving metformin treatment and analyze the kidney GDF15 synthesis to find out whether kidney GDF15 synthesis also increase in humans receiving metformin intake. We will also seeking for blood and kidney tissues from the tissue samples from the same individuals to analyze the correlation of GDF15 levels in the blood and kidney to confirm what we found in our current napkin data analysis. For the rodent study, we will explore the potential molecular mechanism inside the kidney that mediated metformin-induced GDF15 synthesis, try to find a more efficient way to trigger kidney GDF15 synthesis to treat obesity. And this is our findings. And this study is supported by the TGHRI postdoc fellowship. And I want to thank my supervisor, Dr. Tony Lam, as well as all the lab members. And I also want to express my thanks to the 3 nephrologists, Dr. David Cherney and Dr. Heather Ridge, both from UHN, as well as Dr. Laura Mariani from University of Michigan for the napkin clinical data obtained and analysis. I also want to thank for Dr. Andrew Bodovic, also from UHN, for the metformin concentration measurement, and thanks.
That was wonderful. Thank you both so much for this incredible presentation. We are really, really grateful, and such fascinating information that you guys were able to present. So thank you so much for this.
Thank you.
Thank you.
I'm wondering if anybody on our call here has any questions for either of them.
Before we take questions, I just want to add one more thing.
Absolutely.
Song-Yang, can you go back to the previous slide?
Yeah.
First of all, it was Song-Yang's intention to present our findings in a more general receptive sense, such that we have left out a majority of the actual studies that we have done in illustrating this concept.
Mm-hmm.
But all in all, the future is a very challenging one. That is, because of these findings, I was able to go to different places in the past few months to explore opportunities where we can work with others into particularly looking at the kidney GDF15 levels in humans with or without metformin. It turns out it's a very difficult task to do. For example, the studies brought me to Japan, South Korea, eventually to Spain as well in the next month, to explore these opportunities, because they do have studies, ongoing studies, where they would have kidney biobank, as well as the respective patients' medical records, which it is very important into assessing these future direction that Song-Yang has put in this slide. And it is because the part of the difficulty it is, particularly speaking to this audience, is that kidney was never a focus for obesity research. And it is also quite challenging to take these kidney biopsies for reasons other than diagnostic purposes. So therefore, we are working with very limited supply, but yet there are people around, as particularly in the countries I just mentioned, who have been doing this for the past 10 years, not necessarily for obesity research, but for other research, that they will have kidney tissues for us to look at. And in fact, we have started a collaboration in Seoul where they have looked back to some of the tissues that they have taken, or they even have prepared for diagnostic purpose, and now they are screening for GDF15 level as well as the respective medical records. So it is our hope and our wish, particularly to this audience, and thank to this audience, that organ donation as well as research plays a very big role in this part, and really is to combat this huge obesity epidemics that we have, as we illustrated in the intro. So I'm going to stop here and take questions. And there was one, I believe.
Amazing. Thank you so much, Dr. Lam. Yes, I think we had one from Sean.
Hi there. I'm Sean Delaney. I'm actually at the Alberta Transplant Institute in Edmonton, Alberta, but I'm also a two-time transplant recipient as a hobby. So my questions are probably more from the patient and lifelong kidney patient side, in terms of kind of the implications of your findings for kidney patients and weight loss. My first question is, are there different implications, because diabetes is a pretty good predictor of potential kidney risk? Are there different implications in terms of using metformin as a therapy for a diabetic versus a non-diabetic patient? And also, is there differences on the pre-transplant side, getting ready for transplant, versus using it in the weight loss realm post-transplant? Because, I mean, we have different struggles pre and post in many instances.
Those are great questions.
Thanks, Sean. Is it Sean?
Yeah.
Yeah, all the way from Alberta. Thanks for joining us. That's the beauty, I guess, of Zoom meeting.
Yeah.
Song-Yang, would you like to first take the question, or would you like me to take the question?
Maybe you answer it first, and I'm still thinking about it.
There's different layers to the question, of course, but the most important thing one needs to look at is how metformin stimulates GDF15 synthesis in the kidney, and whether infection and other surrounding environment could affect how metformin affect GDF15 synthesis. Hence the pre and post transplantation question. But other than that, I think we are not in a position to make clinical recommendation clearly, because it's still a very early studies. However, it is important to look at, though, whether GDF15 synthesis in the kidney could be affected by other anti-diabetic medication other than metformin. If it does, then it could have effect like metformin in causing weight loss, or it could do so through different pathways. But it is important to compare the body weight lowering effect as well as the glucose lowering effect of different type 2 diabetic medications, so that we can make a recommendation eventually whether people with or without diabetes could go on metformin, as your original question, as to regulating weight loss. With respect to kidney transplantation, I think there's a lot of issues here with the graft rejections, tissues rejections, and so forth. We do not know whether that itself could cause weight changes. So it will be a very difficult experiment to do. But it is clearly in the right directions, because the implication here is that if kidney is so precious in not just clearing substance, but have a physiological function, if in this case an endocrine function, then it is important to look at it from all different angles. So again, it's not directly addressing your question, but it does give the context and the perspective that we need to address. Song-Yang, would you like to add anything?
Yeah. I think you are trying to ask, like, for metformin treatment in different kind of like obese or diabetic people, is there maybe a different outcomes? And what I can tell you is, first, if people with diabetic kidney disease, I don't think metformin is a recommendation like medication, because if people have like defect kidney function, they cannot excrete metformin efficiently, and the accumulation of metformin in the blood can cause like lactic acidosis, which is harmful. And the second thing is, for most of the cases, kidney injury or kidney disease increase GDF15 synthesis in the kidney as well as its levels in the blood. So if a patient already have like kidney dysfunction or kidney injury or kidney disease, they take metformin, whether it can like further increase the kidney GDF15 synthesis or not. To be honest, I don't think there will be a further increase. So I think if people with like already have like kidney injury, they take metformin, I don't think there will be a further GDF15 secretion. Yeah.
Yeah, thank you. No, yeah, I mean, you're kind of in that classic spot of there's a lot of obesity research out there, and then you get to smaller and smaller subpopulations, kidney patients, then transplant or things like that. I think just because of the era that we're in right now, I don't know why my head is so huge on this camera right now, but anyway, it looks like a hot air balloon. Like, I think you were probably doing this research at the exact same time that Ozempic was blowing up, you know, as an alternative treatment. I know the metabolic pathways are quite different between the two of them, but do you see differences and changes, implications for this being used as a one-time weight loss strategy to get to a target weight, or like the same debate is going on in Ozempic, or as a long-term treatment to maintain a healthy weight? Like, so kind of an acute therapy or a long-term chronic therapy?
Can I take?
Please. Yeah, of course you can.
There actually, for metformin, like whether it can like has a long-term effect on like weight loss, there are some like contradictory studies, because like if you summarize all the studies with like metformin treatment for over 6 months, all these RCT clinical studies, only half of them they show, oh, metformin has a weight loss effect comparing with like their initial body weight. But if you carefully taking a look at all these studies, you can find metformin like seems like has a more strong effect on lowering weight in like obese people as well as elder people. So we think maybe metformin's effect on lowering weight is more efficient and persists in those specific, in some people. For example, if they are obese or if they are elder, the metformin effect seems stronger. And we think that could be because the basal plasma GDF15 levels usually is higher in obese people as well as in the elder people. So if they take metformin, their like blood GDF15 levels can be further increased. And in our studies actually implied the blood GDF15 levels actually need to reach a kind of threshold to like have its like weight lowering effect. So maybe the higher basal GDF15 levels in the blood may help the patients to easier to get that threshold to have the weight loss effect. Yes, that's what I think.
Yeah, I agree. So I guess it depends. So the answer is it depends on the situation and the individual.
Yeah.
Whether acute versus chronic. It depends also the basal level of GDF15 and so forth. But I have nothing else to add.
That's great.
Yeah, I think in Sean's line of questioning too, where we come from, we go immediately to kidney transplant. And, you know, when I'm thinking about the workup process that kidney donors and liver donors go through as
Mhm.
well. There's many people who would love to donate an organ to their loved one. However, they may be overweight or obese, and it is a very long journey to lose the amount of weight that they may need to donate. Do you think something like metformin would be able to support that community as well?
That was literally my last question.
Oh,
Yeah.
Well,
I read
implications
Sean's
for living
mind.
donors. Yeah, well, I mean,
Yeah.
3 years ago, I was, still in the search for living donors, and I had, several dozen come forward, and 3 or 4, were turned down because of, being over a threshold, not even, clinically obese necessarily,
Right.
but many living donor programs want your BMI below an actual number, 30
Yes.
or 32 or whatever it is.
Yes.
And so both, I mean, I understand why you want the weight loss down, for the simpler surgery and recovery, but you also, I think, would like it kept down because your future with only one kidney, is going to, not put as much pressure on that remaining kidney too.
Mm-hmm.
So again, back to the acute weight loss to be eligible to
Yeah.
donate versus B, the chronic use of it to keep the weight down.
Mm-hmm.
Yeah, I mean, this is really, it require more knowledge, especially we're talking about clinical recommendation here and therapeutic recommendation. And weight loss medication is a huge unmet need. So not just to people with kidney disease, as well as potentially for organ donation, but also worldwide. So as to which medication to use, I think is being debated. But for us, though, I think with organ research, we will get closer to the answer. And also with different condition, as what Sean was referring to earlier, particularly with organ access biobank, with the link to medical records, I think it will be very helpful for people like us at the hospital to do basic research, to take the step forward.
Yeah.
No, I think we want to thank you for the opportunity. And I think sometimes you never know what an organ could do with respect to research. Originally, you may have given it for other purposes, but our studies is I think is a witness to the fact that sometimes you don't know what kind of things you could do. And there are other people may come on board and uses the organ tissue for many other purposes that could benefit the world. So I think I appreciate all the donors out there, as well as giving access to these studies findings. And also we're all working together, I mean, to combat various diseases. Obesity is just one of them.
Absolutely.
Yeah.
Well, thank you so much, Dr. Lam, and thank you so much, Song-Yang, for presenting today. We're truly grateful for your support. And what we will do is we'll actually link some of those resources as well in the description of this video, so people can read more about your research and about where they can find more information. And then if we get any more questions from people who have watched this video, we will be sure to send them your way as well.
All right.
Amazing.
Looking forward to it.
Thank you so much, both of you.
Thank you.
Thank you.